In this section of audio PowerPoint, we will be discussing the rheumatic disorders. There are over 100 different types of disorders that we classify as rheumatic diseases or rheumatic disorders that involve the muscle, bones, cartilage, ligaments, tendons, and just inflammation of the joint space. So we will primarily be focusing on osteoarthritis, rheumatoid arthritis, lupus, systemic lupus erythematosus, and gout. But there are many, many different forms of rheumatic diseases, and patients can experience symptoms in varying degrees as well. This is an autoimmune type 3 hypersensitivity disorder. The onset and pathophysiology of rheumatoid diseases can be different for everybody. The onset can be very rapid or it can be more gradual. Either way, we have the effects of an overactive inflammatory response and the autoimmunity where we are basically forming too many immune complexes or antibodies against even our own cells. So there's a triggering event, which is your antigen. And again, the antigen is always the starting point that activates our immune system. In this case, activates monocytes, which will mature into macrophages and the T lymphocytes. The immunoglobulin antibodies are formed, and we call that the antigen antibody complex, or the immune complex. As we discussed with glomerular diseases, these immune complexes will deposit in various areas, but especially the joints and then the glomeruli. Those are two areas that is common for those immune complexes to deposit. So phagocytosis, then once the immune complexes have been formed and initiated, they will start generate that inflammatory reaction, which includes phagocytosis. So this is where we are eating away at some of our own healthy cells as well. This is where the effects happen in our joint spaces. There'll be severe synovial swelling and fluid accumulation, which we call joint effusions. So patients can have edema and pain and actually have a lot of extra fluid in that joint space. Pannus formation, this is a proliferation or infiltration of inflammatory white blood cells in that area of the synovial tissue. And then what happens with the inflammation when the phagocytosis happens is the phagocytosis releases chemicals that will break down the collagen and therefore break down cartilage and other body parts, and chemicals that are going to degrade or break down that area, which results in joint space narrowing. So again, we'll talk about this with rheumatic disease, and it is the same physiology, but again, it's not just the joints. It can affect all areas, all body systems, and as we will see with systemic lupus, it is a multi-system disease, and those infiltrates of the immune complexes will infiltrate lots and lots of different areas, including the glomerulus. So as we discussed in the last slide, when pannus formation, which is the infiltration of white blood cells, occurs, this will extend through the joint spaces and eventually erode the articular cartilage and result in a secondary degeneration process. So there are several things that are occurring, and again, the staging and the progression varies from individuals, but the degeneration we can see three things that are associated with the degeneration. So mechanical stress. So again, the articular cartilage is normally highly resistant to wear and tear, especially on those joints. It's made to have the repeated weight bearing and stress to that joint. But the function of the articular cartilage is to provide that smooth weight bearing surface so that the weight load is evenly distributed and the pressure goes to the bone and not to the joint. So that's the purpose of the articular cartilage. But if we have reduction of articular cartilage, you can see where it's not doing its job. Altered lubrication with joint loading. We want forces to be carried through the joint, so that lubrication will help, and it's squeezed out of the cartilage upon compression of the opposing surface. So when we walk, for example, 3 to 4 times our body weight is transmitted through our knee joint. That's why they say running, although running is such a great sport and great activity, it is definitely harder on the joints versus, say, walking or doing elliptical or biking or something else. Immobility, cartilage degeneration due to joint immobility may result from a loss of that pumping action of the lubrication. So immobility will certainly affect the amount of degeneration as well. So this slide is showing a couple things. If we look at the picture on the left, we see a very strong muscle on the very top before we even look at the joint space. But we do see the synovial membrane that has an increased amount of fluid, and then we have the articular cartilage that's still in place, that's helping as transmitting load or pressure to the bone instead of, so it's helping to decrease the amount of mechanical stress on the joint itself. So that articular cartilage, when it's intact, is providing that smooth muscle and that weight-bearing joint is able to transmit all of that load and pressure to the bone instead of the joint. So, but as you can see in the picture, we see that there is eroded cartilage. So that surface on that cartilage, that line that's on the bone and on the left picture, it has eroded. So our articular cartilage is no longer fully present. We still see it in a few areas, but this is where patients can get bone on bone. So they have that bone on bone, which causes them pain. You also can see the muscle atrophy. And again, the pannus formation, all those little black dots in the picture, is just showing you infiltration of the immune complexes, infiltration of all of those white blood cells. This would be a picture common with degenerative joint disease or osteoarthritis, and this is where we see that joint space that is narrowing. We see the articular cartilage that has been destroyed or degenerated, and then you can see how we can also form those bone spurs. So on the right of the picture, they have the bone space narrowing, but then osteophytes. Osteophytes are the bony outgrowth, or what we call bone spurs. With rheumatic disease, all body parts can be affected by the autoimmunity process, but primarily we have the characteristic inflammation of the joints, arthritis and joint swelling and joint pain, joint stiffness, muscle soreness. So those are really the classic signs and symptoms of rheumatic diseases that we're going to really look at more. Over time, they'll have decreased range of motion, they'll have decreased muscle strength, decreased hand grasp strength, for example, and again, they can form contractures and it can get very significant. But that initial joint pain and prolonged stiffness greater than 1 hour is the primary symptom initially. I should add that with rheumatic diseases, they will have acute exacerbations if it's a chronic condition. So they can have periods where it's more bothersome, and then have periods where they're doing pretty well. So that is pretty typical with rheumatic diseases as well. So treatment goals, the #1 priority is to control the pain. PRN medications, non-opioid medications, acetaminophen, ibuprofen. We'll talk more as to the things that we need to watch for, though, with those medications as far as priority side effects, priority assessments. We want to decrease the inflammation and that autoimmune response. So we have different medications that we're going to talk about for that. So control the pain, reduce the autoimmune response and the overreactive inflammatory response. We want to maintain joint mobility, such as doing range of motion exercises, PT, OT, etc., and we can educate about that, as well as maintaining their strength, endurance, and their functional ability. Again, a lot with the exercises that we teach them to do, and PT and OT can definitely help with that. Bottom line with rheumatic diseases, it's a lot of self-management and self-care and education on what they can do for themselves, what can they do to help maintain the mobility while still not have as much pain. And that's the process that they will work with through medication management and therapy combination. So if we were writing a care plan, we would definitely have acute and chronic pain. They will have impaired physical mobility, depending on which type of rheumatic disease we're talking about. They might have a self-care deficit if you think of a severe end-stage rheumatoid arthritis where their hands are totally contracted. It would be difficult for them to even button a shirt, etc. And again, a lot of lifestyle changes and altered role performance. It may impact their work. It may impact them even having to take a different job. It definitely can impact their caretaking and leisure activities that they enjoy. So this is a big deal. Rheumatic diseases can definitely affect quality of life as well. You can see on this slide that arthritis and rheumatoid diseases is the number one for, for causes of disability among U.S. adults. So again, it's affecting a lot. Back pain, heart trouble, you can see those are the next couple in line that also affect the whole person. So we will first talk about osteoarthritis, otherwise known as degenerative joint disease. So you probably more commonly see DJD, degenerative joint disease. This is primarily the wear and tear rheumatoid disease, and it most commonly affects the larger weight-bearing joints. So again, it can affect the hands and feet, but it is most commonly going to be the knees, the hips, and the spine. So when we take care of our patients in joint camp, they are there with degenerative joint disease or osteoarthritis, and they're having their total hip or their total knee replacement as a treatment option for a better quality of life for themselves. This slide does a nice job talking about the risk factors for osteoarthritis and what are the most probable causes for somebody to have degenerative joint disease. So again, it is most commonly those large weight-bearing joints, so the knees and the hips. So obesity and being overweight is the number one cause of osteoarthritis. So weight reduction is often a very first step or strategy for somebody who may be doctoring with an orthopedic doctor that is having complications and pain and reduced motion due to their osteoarthritis. Repetitive use is also a big risk factor, occupational or recreational. So we see a lot of like cement workers, heavy duty construction workers that are doing a lot of repetitive joint and heavy lifting on those joints. And then we see various athletes. So again, professional football players, people who have played football in college, those seem to be the ones that might be having a total joint replacement even in their 40s or early 50s. So this isn't that they have to be in their 70s and 80s to have degenerative joint disease. We are seeing it at a much younger age. We're seeing a lot of people in their 50s and 60s needing to have their total joint replacement. And I guess the benefit of that is to get it done sooner than later. Sometimes people wait too long and then they've had so many changes that their surgery isn't as successful, or they're older and then they're having a harder time recovering from that big of a surgery. So earlier you saw the slide as rheumatoid diseases being the number one for disability. This is just specifically osteoarthritis. So I think it's just really helpful to see that there are a lot of medical costs and lost work that is affecting people with osteoarthritis, not to mention not having difficulty with their usual activities. So where you see the stare there, that's one of the big things where people finally, make the jump to see an orthopedic doctor and to really make this next step to have something done about it. Oh, and then the bottom right, I guess I should highlight that, of course, 40% of adults with arthritis are inactive. So that inactivity really is increasing the risks of being more obese, more weight gain, diabetes, and heart disease. So it isn't just about osteoarthritis. It's about that inactivity and weight gain that then can contribute to other comorbidities that we don't want. I know this is small to see on the slide, but you could even, blow it up a little bit. But again, it's giving you very specific details about the vicious cycle of obesity and osteoarthritis, the percentages, the amount of people that are having other sorts of complications and problems, lost time at work, reduced walking, reduced activity, etc. So take a look at this. It's pretty interesting. And we do take care of a lot of people with total joints who have osteoarthritis. So it's nice to have a few of these details in our back pocket that we can share with people. And or we can go to the Arthritis Foundation, Osteoarthritis Alliance, and they have a lot of good information on their website that we could print for people too. So while osteoarthritis or degenerative joint disease typically is more so your hips and knees, this is just showing you the picture of the Herberden's node or Bouchard's node, which is basically you can see kind of right at the joint where you get kind of that deformity, and so that can be typical with a typical sign that is very specific to osteoarthritis. But I'm not going to focus on that. I really want to focus on what the differences are between osteoarthritis and rheumatoid arthritis, which we will again be comparing and contrasting once we get to rheumatoid disease. But you will see here that there's a gradual onset of localized joint pain that typically is interfering with their activities of daily living. Joint stiffness for for osteoarthritis is less than 30 minutes. You will see that with rheumatoid arthritis, it is greater than 1 hour. That morning stiffness continues with rheumatoid arthritis, whereas if you think of the hips and knees, they're stiff right away. Once they get up and moving and kind of do a little bit of stretching activity, walking, go get the mail, whatever, they've done a kind of a warm-up of that hip and that knee, their pain and their stiffness usually is much reduced. So that joint stiffness time frame usually is in the morning, but decreases with movement and stretching and typically less than 30 minutes. The osteoarthritis is usually unilaterally initially, but there are many, many people that have degenerative disease of both hips, both knees, etc., but they usually have one that's progressing quicker than another, and so many of our patients will have repeat and do total joints on the opposite extremity at some point in time. There typically is minimal to no edema in the affected joint. We don't see a lot of systemic symptoms or localized edema, where we might see more of that with the rheumatoid arthritis. Tenderness while palpation is possible. Crepitus is really a late finding, so if they're hearing the grinding in their hip and their knee when they move and when they bend, etc., I mean, we know that there's bone on bone to be able to hear that crepitus, so that would be a late sign. Again, the main thing is the joint stiffness, less than 30 minutes, the pain that decreases with movement, because with rheumatoid arthritis, the pain will increase with movement, and again, DJD, knowing that it's primarily a weight-bearing joint. So stiffness or pain less than 30 minutes, pain decreases with movement, and typically affects the weight-bearing joint, so can affect their gait, can affect their range of motion, etc. So those are the primary highlights for osteoarthritis or degenerative joint disease. And again, hopefully you can see the differences between rheumatoid arthritis. We talked about some of them, and we will repeat that information again here in a bit. Diagnostic testing for osteoarthritis or DJD is primarily going to be the history and physical. A lot of what the patient is telling the provider is very helpful, and x-ray. Radiology imaging is not always reflective of what the patient is feeling for symptoms, but is usually pretty accurate about the significance of the joint space narrowing. If there's bone spurs, they can see if there's reduced articular cartilage or where we're at with things. They can see if it's bone on bone. So the orthopedic doctors who've been doing this, who have experience with this is what they see, this is their specialty, they pretty much can know when they look at imaging to see what they think if they are going to be needing surgery or not. Now, insurance companies unfortunately do dictate a lot of things, so they will definitely still have to go through a process of weight loss and cortisone injections and different things like that typically before they can document the need for surgery. It's kind of silly, because if they see that on the x-ray and know that this is not going to get better with these things, I mean, it might be improved a little bit, but it's ultimately not going to fix the problem. But they have those controllers that are, managing healthcare and making sure that people are having things done when there is a need, and that they have tried less invasive things first. So I do know that is one of the things that the doctors have to deal with. Lab tests, now again, the lab tests are not specific for osteoarthritis, but if we have an inflammatory process, if we have an autoimmunity going on, this is an autoimmune disorder, we would expect to see the C-reactive protein and the erythrocyte sedimentation rate to be elevated. Those would be elevated with any inflammation. So they are not specific for inflammation by degenerative joint disease, but they would be elevated also with rheumatoid arthritis, with gout, and with lupus. Rheumatoid factor, they could have a positive rheumatoid factor with rheumatoid arthritis. But so I guess they could do that to rule out rheumatoid arthritis, but it's not, specific, I guess, to just degenerative joint disease. Arthrocentesis, this is where you would actually do a needle aspiration of the joint, and this can help with further diagnosing of gout or infection and just how the fluid in that space is looking and what it's testing positive for. Here is the treatment approach that I sort of already alluded to. Non-pharmacological interventions initially, education, exercise, range of motion, weight loss, all of those things. Again, weight reduction being number one that needs to happen first, but even yoga and more of stretching type exercise activities, applying heat if that helps, avoiding overuse. Those are all non-pharmacological things that we can try. Topical, again, there can be topical Bengay, capsaicin capsaicin or lidocaine patches. Those are all topical agents that can help with local anesthetic type property. NSAIDs, your nonsteroidal anti-inflammatories, as far as reducing the inflammatory process, because that is really hitting what we're doing, what's happening here with this disease. But we have to be careful about long-term NSAID use as far as GI bleeds, GI ulcers, etc. Or other oral agents, acetaminophen, NSAIDs, and SYSADOA. That stands for slow acting symptomatic drugs for osteoarthritis. Those are things like glucosamine or chondroitin, and they'll be coming up here on a slide, that can kind of slow the progression of osteoarthritis. Of course, opioids would be a last. We do not want to go into opioids unless we absolutely have to. Duloxetine is actually an antidepressant. That one's listed there, but it can also help with muscle pain, tenderness. Again, there can be concurrent depression with rheumatoid diseases, so that might be possible. Intra-articular injections, we'll talk about corticosteroids, cortisone injections being the most popular, but we also have a hyaluronic acid, I can't say that right now, injections, and so those are possible, especially if the cortisone is not working, and then surgery. So again, we might have to go through a few steps and stages to get where we need to be, but a lot of people will ultimately require surgery. So this is a really important slide for the pharmacology and the medication management for a lot of rheumatoid diseases. And also you can just relate what you learn here in talking specifically about osteoarthritis to when you're giving Tylenol or ibuprofen or Mobic to other people for other conditions. So it's really important to be able to generalize our knowledge and use it, pull it to where we need to use it for something different also. So it's kind of a review of pain management, if you will, but also very specific for the rheumatoid diseases. So again, part of it I already talked about in the last slide, but the analgesics, the first line agent would be acetaminophen or Tylenol, because there's not going to be the bad side effects like we see with NSAIDs as far as GI. However, we do need to make sure as far as acetaminophen, the 4,000 grams, not to exceed 4,000 grams a day, and the liver toxicity part with the acetaminophen. With tramadol or Ultram, that is an opioid, so again, we're not going to just start people on tramadol because it can be addictive, or it would be addictive if they're using it long term, but some people that would be like a stronger type pain medication if needed. You've probably heard of cyclobenzapine, which is Flexeril, and Flexeril is a muscle relaxer, and so that works just slightly differently, and that can possibly be helpful. But again, that one is considered a little stronger, so we wouldn't just jump to that before trying other things. Our anti-inflammatory medications, we have our standard NSAIDs such as ibuprofen, and then we have the category that you've probably heard of, the COX-2 inhibitors. The benefit of the COX-2 are that they decrease the risk of GI bleeds. So that is very, very helpful. So you'll see our orthopedic doctors order meloxicam or celecoxib, so Mobic or Celebrex, and they will order those medications routinely after surgery to, in addition to the acetaminophen. They'll have those scheduled to reduce the amount of opioid need and to help with the actual problem, which is the inflammatory process. So that's what's very helpful for the COX-2 inhibitors. COX-2 inhibitors can cause cardiovascular disease increase in MI, and kidney problems. So they're not without side effects, but they are much more likely to be prescribed and have much reduced risk of the GI bleed risk that a regular NSAID would have. The other thing on the standard NSAIDs that I didn't mention, obviously our two priorities, just to reiterate, is the GI bleeding and the ulcers, but then also remember that NSAIDs are nephrotoxic. So I just wanted to point that out again to make sure we were all on the same page with that very important assessment and potential complication of NSAIDs. Dietary supplements, a lot of patients will swear by this. The glucosamine slows down. It decreases the inflammation. It decreases the breakdown of the cartilage. So it doesn't fix the problem ultimately, but it can help slow it. And so that can be helpful. And then chondroitin sulfate, it can strengthen the cartilage. So either way, both of those dietary supplements are helpful in reducing the breakdown of cartilage and slowing down the breakdown of that cartilage. Intra-articular injections and the cortisone, you'll see that can be given every 3 months, so 4 times a year maximum. They will do that cortisone injection right into the intra-articular area of the joint that is affected. If the cortisone fails, they can do the hyaluronic acid, which is a rooster comb. That's kind of the lay term that you may have heard, rooster comb. And it's a gel. It's a little bit more of a gel material than liquid, but it is definitely still an injection. It is approved by Medicare currently for knees only. So if you are having knee problems, it'll cover it, but not covered currently for shoulders and hips. Now the hyaluronic acid injections will be weekly for 3 to 5 weeks, and then they can repeat every 6 months. Topical, I have a bunch of the topical listed. Again, you need to know the generics of all these names, so I'm trying very hard to put the generics and the trade names so you can learn them together. Some of the agents you may recognize, the Bengay and the Aspercreme, but not necessarily recognize the methyl salicylate. So I just wanted to make sure that you're looking at that. I think most of you have probably seen lidoderm patches, and those lidoderm patches can be very helpful for many types of pain conditions that have chronic pain, but certainly for rheumatoid diseases and osteoarthritis. So we'll see them a lot with osteoarthritis of the back, and they'll have them on their lower back area. So I've added some extra slides just to make sure that we really are getting all of the important information for ourselves as the practicing nurse, but also client education, medication information for our clients. So with the Arthritis Foundation, of course, is a very helpful site. There's a lot of self-help courses and things that they can do and educate themselves independently, and you as nurses could do as well. It's really helpful. I remember reading all of the client education packets and handouts because as I read those that were simpler, that helped me to understand it better, and it also helped me to be able to explain it in a more simple term in the future. Weight loss, of course, is our number one, and that's the first strategy that we will do. And then I basically just have some highlights and have broken down some of the medication categories a little bit further. So the acetaminophen, you'll see the not exceeding 4,000 milligrams a day, and it's a 25 milligram a day if taking with warfarin or Coumadin. We know that the main organ that we're concerned about with acetaminophen is liver toxicity, so there's caution with consuming alcohol because of the liver toxicity piece of it. NSAIDs, we talked about the GI bleeding, be huge, and also using it for shorter durations and using the lowest dose possible for the shorter durations. I mean, acutely, some of our orthopedics might order 800 milligrams at a time, which is 4 of our over-the-counter like Motrin. That's for short-term use, and that higher dose might be necessary for very acute inflammatory conditions, but we shouldn't be taking 4 ibuprofen multiple times a day for a long period of time. Certainly that would be more than what we would want. Again, we have noted there to avoid in patients with pre-existing renal conditions, or at least to know what their renal function is, because NSAIDs are nephrotoxic. And then monitoring creatinine. Again, if they're on ACEs or ARBs, because ACEs are nephrotoxic, we're giving 2 nephrotoxic medications together, which is why we want to pay attention to that detail. Other client medication education, the tramadol is listed there. This, because it is an opioid, is contraindicated with alcohol, hypnotics, other narcotics, may definitely be used in combination with NSAIDs or other things. One thing that you want to make sure, though, on the tramadol, or you may see people on Flexeril, tramadol or Flexeril, basically. I wanted to point that out with either of those. Sometimes we see people that are chronically on that. Again, it isn't something that we would prefer to them to be on more long-term, but some people with chronic pain are. So if they come into the hospital for something else, we may be giving them short-term narcotics for whatever they're there for, their surgery or their extra pain different than what their chronic pain is. So while I have contraindicated with it, because we don't have patients do that at home, I just wanted to point out that sometimes they may be taking a more short-term IV or oral narcotic in the hospital and still taking their regular scheduled tramadol and or their regular scheduled cyclobenzapine, which is the Flexeril. Topical agents, then we've talked about that to make sure that, we wash our hands. We don't want to touch our eyes after we apply that. Obviously, in the hospital setting, we will have gloves on as healthcare providers, but for patients, of course, they don't want to, touch their eyes and then have Bengay in their eyes and it burns like crazy. So they shouldn't shower immediately right after application. They shouldn't cover it. They should just put the amount on that is prescribed on the package as far as how thick, it's usually more of a thin layer that we are expecting to see put on for these topical agents. And then the intra-articular injections, I've already kind of highlighted this, but this will be done at the doctor's office. The orthopedic doctor will inject these medications, and you see kind of the protocol for how often they will do those. So next then is rheumatoid arthritis, and again, I really want you to be able to compare and contrast the difference between rheumatoid arthritis and osteoarthritis, and there is a nice table in your textbook on that as well. Again, they're both rheumatoid diseases. They're both autoimmune. This is where we have genetic factors, though, that typically will stimulate the production of these autoantibodies or rheumatoid factors that attacked our own self. So it still is the type 3 hypersensitivity that's activated by both the B and T cell lymphocytes, and that will cause that overactive immune response. So remember, degenerative joint disease is osteoarthritis, and the rheumatoid arthritis is more so common in the hands, feet, etc., where the DJD is more so with the larger spaces and the larger muscle compartments and joint spaces. So this slide shows you where we have the start of the activation of the process. As soon as the antigen is presented to the T cells, the antigen, which is seen as foreign, is sent to the T, is presented, it's going to produce its antibody against it. Remember, the B cells will produce the antibody response, then will form those immune complexes. And then the T cells have T cytotoxic. They can do their own killing on their own. They can help the B cells. So when we say the T and B cells together, working together, they are both working basically at the same time, but it's an overreaction immunity to your own self. Neutrophils then will accumulate. You'll see that in the middle box there, neutrophil accumulation due to the inflammatory process. So the normal inflammatory process, in addition to the specific cell and antibody mediated, is still working. So all of those neutrophils and white blood cells are basically going to be accumulating, and then they're going to be deposited. Those immune complexes are going to be deposited in the joint spaces. So ultimately, phagocytosis is going to occur, and this is where we have phagocytosis that produces enzymes within the joint. And these enzymes within the joint that are helping with the phagocytosis are breaking down the collagen. That breakdown of the collagen, the degradation of the cartilage, is ultimately where we have what we call pannus formation. So pannus is that newly formed synovial tissue that's infiltrated with the inflammatory cells. Either way, we say a T and B cell response, neutrophils that are going to go to that site of injury and inflammation. We're going to have the buildup of all those white blood cells and immune complexes that deposit those enzymes that are going to break down the cartilage, and eventually with articular cartilage that's being broken down, we will have bone erosion. So a lot of technical terms on this slide, but hopefully in how I explained it kind of helped with the physiology. And I really like on this slide off to the right, you will see the swelling of the joints, the pain, the stiffness, the warm. It can be swollen, decreased motion. Again, it's giving you all of the key signs and symptoms of rheumatoid arthritis. It's associating with the pathophysiology as well, which I like. So this picture does a really nice job. On the left, you can see the normal joint, the joint space, the synovial fluid, the cartilage, etc. And then you can see how that cartilage is thin. And then those orange and red areas, you can see pannus formation. Pannus is where we have all of those cell types, the lymphocytes, the macrophages, the neutrophils, all of that white blood cells that are infiltrating that area. And again, once they infiltrate, the phagocytosis process is to release enzymes that are going to break down. Well, that enzyme then is breaking down your own articular cartilage in that joint space. So this slide is really nice to see the early versus late signs of rheumatoid arthritis. And we'll talk about, well, the next slide is late, but this is looking at early joint and early systemic signs and symptoms. Again, usually early is going to be more of that warmth, stiffness, tender, painful on palpation. may have some erythema. Again, joint pain typically is greater than 3 months. It's gonna, I mean, initially, remember, it's greater than 30 minutes because that was a differentiator between osteoarthritis. Osteoarthritis in 30 minutes, usually once you got up and stretched, it got better. In this case, the joint pain will last longer than 30 minutes, and it's going to be pain more days than not. So that's where it's going to last a lot longer. And again, there might be more pain with movement, where with DJD, the pain was better with movement and mobility. So looking at the signs and symptoms, they may be mild initially. They may have paresthesia, some numbness and tingling sensation. Again, kind of depends on how many symptoms they're having before they would actually get help, seek help. So you can see we have a lot of patients that probably don't go to the doctor initially for early manifestations of rheumatoid arthritis. They might wait till it's much worse and pain is worse, etc., before they go get checked out and even diagnosed. So here are more of the late manifestations. So things just keep getting worse as far as the pain, the stiffness, deformities, etc. They still can have some of the same systemic effects as far as fatigue and lethargy, but it does get worse. They get more, osteoporosis, weight loss, and other systemic problems and complications that arise because of the arthritis. But again, look closely. Rheumatoid arthritis, morning stiffness greater than 1 hour. DJD is going to be morning stiffness less than 30 minutes. Effusions, meaning they have the body cavities that are building with fluid. There can be effusions with both OA and rheumatoid arthritis. But deformities are very, very common. Again, this is most commonly the hands, especially for rheumatoid arthritis, and the feet, but the hands can get really, really deformed. You've probably seen some people with late manifestations and pretty severe contractures with their RA. And then pain, again, that pain and the stiffness and the joint pain and the deformities and the loss of range of motion, all of those things are very, very severe and can really alter their ability to care for themselves and do their normal activities of daily living and or their normal work. So remember, with rheumatoid diseases, while we may have a certain part of an extremity or the hands, bilateral hands that are affected, all of the overactive immune response is affecting all body systems. So while I'm mainly focusing on the mobility of that musculoskeletal system and the hands, as you can see on that last slide too, it showed you all of the body systems that also can be forming nodules and having problems. This one kind of talks about it as well, as far as the rheumatoid arthritis vasculitis, where we can see some of those changes, the splinter hemorrhages around the nail. Again, you can see the obvious contractures and late rheumatoid arthritis where they have significant deviation of how the hand is supposed to be situated, and certainly can affect their range of motion and their pain. Again, you can see the other nodules on the bottom left where they have some of the common sites for other nodules to form kind of by the elbow area, etc. So there's lots and lots of things, including dry eyes, dry mouth, dry reproductive vaginal area, other things that can happen as a result of the rheumatoid arthritis. So definitely want you to focus mostly on the musculoskeletal aspect, but I want to make sure that you understand that there are other things that are affected with RA. So when we look at lab testing, there's many lab tests that could support a diagnosis of rheumatoid arthritis, but none that are going to necessarily confirm it. But we go by, we'll use imaging and x-rays. Certainly we can see the actual deformities. They can listen to what their patients are telling them about their pain, their motion, their joint swelling, the stiffness, etc. So a lot of it is clinically present on what the practitioner can see. They might also have some of those extra articular changes, so the non-joint stuff, the fatigue, the weight loss, the lymph node enlargement. So looking at all of those things, it's not just a test that's done. A lot of things we look and we have a test that confirms, and with rheumatoid diseases, it's not quite that simple. So looking at the clinical picture, doing all of your musculoskeletal assessment, but then also all of those extra articular or non-joint changes that can occur are very, very important. What we've talked about so far, we talked about the rheumatoid factor. This is positive in about 80% of cases cases with rheumatoid arthritis. But if somebody has a rheumatoid factor that's negative, 20% of those people could still have the disease. So it's not foolproof, it's not an absolute confirmation, but it is something that is closely linked with rheumatoid disease, whereas it's not linked, for example, with osteoarthritis. Anti-nuclear antigen will be positive. It's the higher the titer, the more the inflammation. So it's positive with inflammatory conditions, again, not specific just for RA. Same with ESR, same with C-reactive protein. We would expect both of those to be elevated in somebody that has rheumatoid arthritis and or elevated in anybody that has an inflammatory process going on. CBC, why we want to look there is because we know patients can also have difficulties with anemia. We could expect their total white blood cells count to be elevated as well. Arthrocentesis, this is where they're doing a synovial fluid aspiration. And again, somebody with rheumatoid arthritis could have very cloudy, milky, dark yellow. I mean, it's a really gross, cloudy color and look to it. And all of that is all of the leukocytes that are present. And they can test that fluid for more detailed information. Again, x-ray imaging, they could do other tests if organs are involved. Again, when we get to lupus, for example, they're going to do kidney testing because they're concerned about infiltration of the glomerulus. And then on the right, you can see the pictures. I like how it's showing you the IgG and the IgM. This is the type 3 hypersensitivity. Again, this is where we have these autoantibodies and these immunoglobulin or immune complexes that are basically gaining access and infiltrating and deposit themselves in all areas of the body, but in particular the joint area. I will refer you to the Arthritis Foundation for lots of great information, and we should also be doing the same and giving these specific resources and websites to our patients that might be wanting to get on the computer and do some of their own teaching and training. It's a very, very good resource. With all rheumatic diseases, again, there's not a lot of differences as far as PT, OT. We said how important that was for degenerative joint disease. It's equally as important for rheumatoid arthritis. Weight loss isn't as big of a deal typically with rheumatoid arthritis because it's not typically obesity that's causing it, but certainly if the person was overweight, that certainly is not going to hurt anything to have some weight loss. But the exercise, the range of motion, the exercises that PT and OT are talking about are super helpful. If we look at occupational therapy, the occupational therapy is more of the small joint movements, whereas the physical therapy is the large muscle and joint movements. So occupational therapy will really be very, very specific for the RA, especially if it's affecting the hands, because they can help with adaptive equipment, assistive equipment, joint protection, splints, braces, and more specific exercises that they would instruct specifically for the hands versus PT. There are also specialized trained occupational therapists that are trained just in hand therapy, so they will work with patients with hand injuries for other reasons, but also with rheumatoid arthritis. Chiropractic care can be used for people, other, non-pharmacological and kind of non-medical or more holistic as far as acupuncture, meditation, relaxation. All of those things are certainly a possibility for people. The other thing, and we have the picture of the pool here that I want to highlight, is aquatic exercise is a huge benefit. Evidence-based research proven that water supports and it helps with the movements. We can move better and do better range of motion in water. So when we have to resist the movement, we have to work kind of against that water resistance. We're going to do better. We're going to get more out of it. Warm water also, water temperature of 84 to 92 degrees is very, very good. So the water aerobics and exercising that a lot of our snowbirds are doing is excellent. And a lot of even indoor health clubs have heated pools that are going to be really excellent for patients for just healthy living in general, but certainly for joint mobility and those that are suffering from rheumatoid arthritis and or osteoarthritis. So with rheumatoid arthritis, they still might use some of the same analgesics, the acetaminophen, the NSAIDs, the nonsteroidal anti-inflammatory drugs, the COX-2 inhibitors. I don't have all of those listed again on this slide because we've talked about them. It does highlight again on the NSAIDs, making sure, it talks about monitoring renal function because NSAIDs are nephrotoxic, but then also it talks about considering a PPI, a protein pump inhibitor, or a histamine 2 blocker. Again, if we think about NSAIDs having that possibility of GI ulcerations and GI bleeding. That's why some people, if they need to be on it for a little longer than normal, might also be on an anti-ulcer agent of some sort. DMARDs, disease-modifying anti-rheumatic drugs. The DMARD categories, and I have a slide, the next couple slides will talk about it. There's a table in your book that has all of the DMARDs on it, is very effective for patients with rheumatoid diseases and this autoimmune disorder. So the disease-modifying anti-rheumatic drugs. Again, for active disease, we really like these to be started within the first 3 months. Combination therapy, so using DMARDs in conjunction with other things can also be helpful. And then we have the biological response modifiers that are also another category. And you see some of these names. You'll see the Enbrel, the Remicade, the Humira. Again, I have the generic listed there because we recognize those trade names because of the commercials, but I want to make sure that you recognize those generic names as well. And then steroids. You know, we can give steroids into the large joint spaces like the hips and the knees with DJD, and they can also do steroid injections, but not as likely on an injection side of things. It would be more likely to be oral prednisone, but again, we don't want patients to be on long-term steroid use. So if they're having an acute exacerbation, this might be important. This might be something that they would need to be on, but typically wouldn't be something that they are on forever. Antidepressants, you'll see those used for rheumatic diseases, especially if they're having difficulty with sleep deprivation. Trazodone, which is an antidepressant, is used more readily for sleep and keeping people asleep, and just in general, depression, body image changes, just quality of life, all of the things that go along with rheumatoid diseases can affect the psyche, and so antidepressants are, you know, not uncommon for people with rheumatoid diseases. Some of the new patient education that we haven't yet talked about with the DMARDs, in particular methotrexate, that is Rheumatrex, but methotrexate is the generic. That is a gold standard for advanced rheumatoid arthritis, but it does have very serious side effects. It can be very highly toxic, in particular cause bone marrow suppression. So decreased white blood cells, decreased platelets, can cause decreased red blood cells or anemia as well, and can cause just some of the GI disturbances. So again, we'll be talking a lot here once we get into oncology about immunosuppression. We've already talked quite a bit about it in hematology, but that would be a major teaching point with the DMARDs. If they are on that medication, that they understand that they are at a higher risk for infection, that they should do some of the avoiding crowds or wearing masks, avoiding ill people, etc. They may get stomatitis or those sores in the mouth and lips. That's more possible. Again, they may have hair loss, not always with that, and they may have more of an overactive GI tract and diarrhea that they have to kind of deal with. So again, a medication that is really good for advanced rheumatoid arthritis, but it definitely has some significant side effects. And you can see strict birth control if you were a woman of reproductive age, avoiding alcohol when taking DMARDs. And then the last education piece there is the corticosteroids, prednisone and other types of category of steroids. Any of those that end in SONE are corticosteroids, so you can recognize those generic names very easily. And again, those steroids, the purpose of the steroids is to suppress that inflammatory response, so it can be very, very helpful, but long-term steroid use has a lot of very negative side effects, which we will be talking more very thoroughly about in the endocrine system. But not to mention increases your blood sugar. You guys probably know that one for sure. But a lot of other skin changes, makes the skin thin, muscle wasting, bone demineralization, hypertension, weight gain, moon face, buffalo hump, psychoses. There's just oodles and oodles. So you need to know the side effects of corticosteroids because we need to teach our patients about that. We have patients on steroids for lots of conditions. I can think of this semester, you've already talked about the need for steroids for respiratory conditions. Here we're talking about it for rheumatic diseases. We'll talk about it again for immunosuppression. We'll talk about it again for with skin conditions where they have to have maybe steroid creams, etc. So we're going to be hearing a lot about it here this this semester. So if you haven't already done your due diligence on steroids, you want to make sure you kind of add to this list here of what are some of the key side effects that you're going to be watching for and teaching your patients about. This picture is showing you some of the physiological difference of rheumatoid arthritis and osteoarthritis. I am definitely more wanting you to make sure you know the differences clinically and what our patients are going to report as far as pain, as far as motion, etc. Again, the causes, the weight-bearing joints, the wear and tear disease, which is known for osteoarthritis, the wear and tear for degenerative joint disease, and versus the rheumatic disease, the rheumatoid arthritis. But certainly this is really good to see the differences. There's a nice table in your book also that goes through quite a lot of the differences. Systemic lupus erythematosus, SLE, which is usually abbreviated lupus or SLE. Again, this is another autoimmune type 3 hypersensitivity. You'll see more commonly that 20 to 40 year age group of being diagnosed with lupus, and it is 10 times more common in women, 3 times more common in African American women. 3 times more common in African Americans, but if you're an African American woman, then obviously your risk is there as well. Again, we have the autoantibody being produced. We have the deposition in all body systems of those immune complexes. One of the most important complications that we want to try to monitor is glomerular nephritis. So again, those deposits of the immune complexes in the glomerulus. The glomerulus is where we do all of our filtering, and if we have decreased GFR, then we have signs and symptoms of renal failure. So that's really important to stay on top of that. Again, this is a fluctuating type disease. It is a chronic condition. If you have lupus, you have it. It is chronic. There isn't a cure, but they're doing lots and lots of research and trying to come up with good plans and good management for lupus. Again, there is multi-system involvement. These immune complexes deposit in all areas, and then we have the phagocytosis and the inflammatory response that cycles continuously. So again, key symptoms will definitely be the arthralgia and the arthritis, the joint pain, and that arthritis and some of the things that look similar to like what we just talked about with rheumatoid arthritis, but it will also definitely can result in more long-term systemic complications. So I really like this slide that just visually goes through the clinical manifestations for lupus. One thing that you see the big sun there, they are very photosensitive. About 50% with lupus will have a butterfly rash over the cheeks that is provoked by the sunlight. So that photosensitivity is directly linked to that butterfly rash that you'll see over the cheeks, or it will what's the word I'm looking for, that it'll make it worse. I mean, they can have a butterfly rash without the sunlight, but that is going to definitely precipitate it and provoke it to be more prevalent. Arthritis, and again, very, very common if you look musculoskeletal wise, that they could have arthritis, they could have fatigue, they could have some of those things that go along with that. They also can have a hematological disorder such as anemia, leukopenia, thrombocytopenia, again, low red blood cells, which can contribute to their fatigue, low white blood cells, which contributes to their risk for infection, and low platelets, which can contribute to them being, bruising more easily. If you take a look at the bottom right corner, I want to definitely highlight the glomerular disease problem. So glomerular nephritis, again, this is when we had the white blood cells that basically clog up, infiltrate, form scar tissue in the glomerulus, and results in decreased glomerular filtration rate. If you remember back, if we're not filtering everything like we are normally supposed to, protein and blood is going to spill into the urine. So we would expect proteinuria and hematuria for any patient with a primary glomerular disease. And in this case, if they have a complication of glomerular disease with their lupus, they could test positive for protein in the urine and blood in the urine. Again, chronic kidney disease is a leading cause of death for people with lupus, so they definitely, as a result of their lupus, could end up with end-stage renal disease at some point in time and end up dying from their chronic kidney disease. So monitoring urine function, monitoring their serum creatinine, checking UAs for protein and blood in the urine is super important to see how their body is responding to this disease, and we really want to try to prevent and delay any complications to the the renal system. But renal failure, hypertension, all of those things are really, really big deals for patients with lupus. Now, people with lupus, if you look at the top left to the lungs, they are more prone to pleural effusions, so they can build up extra fluid and pleuritis and cough and things that associate with that. Bottom left, you'll see the heart. There's a lot of people with lupus that have Raynaud's phenomenon. And remember, we talked about Raynaud's where they have that sensitivity and that vasoconstriction when they get cold, so keeping their extremities cold. They also have more of a chance of pericarditis or inflammation of the pericardial lining. And so we want to be listening and hear if we hear a friction rub at all. They do have earlier atherosclerosis, so they do have a lot of cardiovascular risk factors, more increased risk for stroke, MIs, and all of those things that we know associate with atherosclerosis. So because of their early atherosclerosis, they do have more chance of cardiac events at a younger age. Remember, 20 to 40 years of age is where this was mainly diagnosed. So we have a younger population that are having to really be mindful of cardiovascular and kidney, especially those body systems that can really cause them early problems or complications. Heart disease is the second leading cause of death, whereas we said the kidney disease was the first leading cause of death. So those are really big findings in a patient with lupus. One thing I forgot to add on the last slide, we talked about all the different, the butterfly rash, the arthritis, the different kidney and cardiovascular and lung changes. All of those are super, super important. But I wanted to add that pregnancy and use of oral contraceptives can also affect the person's estrogen levels, obviously, and that can increase the risk for flare-up. So that's just another point of reference that can impact acute exacerbations of the lupus. So management is avoiding that exposure to the sun. Remember, sunscreen and preventing those exacerbations and flare-ups of that butterfly rash and just burning their skin, etc. Health promotion, there's a lot of routine follow-up visits. These people need to see their doctor, you typically more than just annually for management of checking their labs, checking their urine, watching their cholesterol, atherosclerosis, watching their GFRs and their serum creatinine. All of those things are very, very important to prevent systemic complications. So they really should have a primary care doctor that's really watching them closely. As far as medication, the single most important medication typically is a corticosteroid that's going to treat the inflammatory response. So again, typically they'll have an acute exacerbation, which is where that inflammatory response is going to be more active and where the steroids are going to be most beneficial. You might also see anti-malarials such as Plaquenil that can manage some of the cutaneous, the musculoskeletal signs and symptoms. Plaquenil is renal toxic, so we definitely want them to be drinking lots of water and be monitoring renal function while they're on that. Patients may need to be on immunosuppressants and other actual immunomodulators to help with management of their disease, especially if they're not responding to other conventional treatments. And then globulins, again, this is going to promote specific immune function, so they may need IgG infusions, IgM, they may need infusions, but primarily IgG is the infusion that they may need to make sure that they have that specific protection against bacterial infections primarily. So remember that IgG was the 75% of our immunoglobulin was IgG, and that was really important for our immune protection and in protection against bacteria. So gout or gouty arthritis is our last rheumatoid condition that we're going to be talking about in this section. Attacks usually last anywhere from 3 to 10 days, followed by symptom-free periods. With time, the attacks can happen more frequently and can last longer and can actually start to invade more areas or joints. But typically, the biggest area for the joint pain primarily is the big toe, and you will see in this picture where the urate or the uric acid buildup forms crystals and causes the problem. So if we look at it's an inflammatory condition, again, it's genetic. It's a genetic defect of purine metabolism. It's important to understand that purine in the diet breaks down into uric acid. So if we have extra purine in our diet, or if we genetically have a problem with purine metabolism, we are going to have an increase in uric acid. So hyperuricemia. Elevated uric acid would be what we would expect to see in somebody with gout. So again, understanding that purines in the diet will break down into uric acid will help us to understand why our patient would be on a low purine diet, or why the causes, as you can see, are oversecretion of uric acid, decreased excretion of uric acid, or increased purines in the diet, which again, purines break down into uric acid. So bottom line, elevated uric acid, I know that you guys know that. Acute attacks may be triggered by trauma, alcohol ingestion, dieting, surgical stress, illness. So there might be some reasons for a flare-up, but otherwise, again, usually you have periods of remission and where you have symptom free. But patients will come in with severe pain, swelling, warmth of that area, and redness. So a few differences for medication management for gout. I want you to pay attention to the acute gouty attack versus the chronic. The acute gouty attack, they're going to use ibuprofen, use the traditional nonsteroidal anti-inflammatory drugs to, of course, reduce the inflammation and reduce the pain. They will also use colchicine, which I know you've heard of, and that reduces the deposits of the uric acid. It doesn't actually alter the uric acid levels, the total uric acid level, but it reduces the depositing of the uric acid into that area, which is causing that autoimmune response. So colchicine for acute and ibuprofen for acute. If they're having more repeated episodes and they have what we call chronic gout and they're having them more frequently, the episodes are happening more frequently, they would likely be started on allopurinol. Allopurinol is going to actually reduce the uric acid levels in the body. So it's going to interrupt the breakdown of purines, which then will reduce the amount of uric acid, because uric acid is a byproduct of purine breakdown. So allopurinol would be more for chronic, colchicine would be more for acute. So you recognize both of those. You see those right away, and people usually know gout. I just wanted to point out when they might be used a little bit differently. With allopurinol, it can cause some GI stress, again, because this would be one that they would be more on for a chronic gout. We want to make sure that they understand that it can cause some GI distress, that they could take it after they've eaten or once they have something in their stomach. And again, the other thing here, which is good for all patients with gout really, is to drink a minimum of 8 glasses of water a day. The allopurinol can really be hard on the kidneys, so that's why we want to have water. But just think about water for helping to excrete more uric acid in general. If we have more water and we urinate more, we're going to be excreting more of that uric acid also. So that's also why I feel like twofold that we want to talk to our patients about why water is important if they have a history of gout, and obviously if they are on allopurinol. And then finally, management of gout as far as nutrition therapy would be to restrict consumption of foods that are high in purine. So foods high in purine, foods that they really should be avoiding: organ meats, shellfish, oily fishes, anything with fish with bones, and then alcohol. Alcohol can cause a buildup of uric acid, especially beer, so that is something that they would want to avoid. Starvation diets are known to trigger gouty attacks. I had mentioned that, so we want to stay away from that. Again, drinking plenty of water. Water is going to help the body, the kidneys normally excrete more uric acid, but also going to help, which I haven't mentioned yet, to prevent the formation of kidney stones. Remember that uric acid stones are a possibility and might definitely be obviously a higher risk possibility with somebody that has increased uric acid. And so we want to have lots of water to flush out the uric acid, reduce the uric acid in total, but then also to prevent the formation of stones of that elevated uric acid level. Citrate fruit juices, milk, dairy products, those can be helpful as well. So again, most importantly, patients may identify foods that trigger their own gouty attacks, and they should just stay away from them. And again, it kind of depends on how often you're having the attacks, whether or not, how strict you have to be on this. But this, NCLEX wise, we know a low purine diet, and you should be able to know some of the food items that are associated with that.